So now I invite Dr. George to talk on impact of TVT study on my surgical management.
Thank you, LF Hospital and KSOS for this opportunity. So this is the primary paper, the treatment outcomes in the tube versus trabeculectomy study after 5 years of follow-up. I must acknowledge that Professor Steve Gady has played a vital role. He has been guiding and helping us in our journey with the non-valvular glaucoma drainage device. He has been the mentoring author in many of our publications. And I've also got some data from many ancillary papers in this TVT study. So the purpose was to compare the safety and efficacy of tube shunt surgery and trabeculectomy with mitomycin in eyes with prior ocular surgery. So 212 patients with uncontrolled glaucoma who had undergone cataract extraction with IOL implantation and or failed filtering surgery. So my concern here is there is a large number of patients who are at a lower risk of failure, of surgical failure, because they are just clear corneal phacoemulsification patients. Again, randomized to a 350 millimeter square to receive either a 350 millimeter square barbell glaucoma implant or trabeculectomy with mitomycin. In the TVT, they used 0.4 milligram for 4 minutes and they used a limbal based flap. Again, a concern because, as has been mentioned earlier, there have been many more modifications with most of the surgeons shifting over to the phonics based conjunctival flap. Again, I'm not sure whether many of our ethics committee will allow a 350 millimeter square barbell glaucoma implant as the initial surgical procedure of choice for a secondary glaucoma associated with a secondary pseudophakic glaucoma. So the study group managed to get two well randomized comparable groups with an IOP of about 25 millimeters of mercury on an average of 3 glaucoma medications, and most of these patients were primary open angle glaucoma patients. All the baseline ocular characteristics were comparable in both the groups. So this is the intraocular pressure control in the study. As can be seen, the early intraocular pressure control naturally was much better with the trabeculectomy group. And after about 6 months, there was no significant difference between the two groups in the mean intraocular pressure. So this early intraocular pressure control could also be attributed to the type of the implant they used. Again, the number of anti-glaucoma medications were much higher initially in the tube group, but after about 3 years of treatment, it was almost the same at the end of 5 years. And what is interesting to see here is there was a steady increase in the number of glaucoma medications in the trabeculectomy group, and the tube group, most of the number of glaucoma medications seems to be remaining static. Again, comparable to what we see in our clinical practice. Treatment outcomes, the failure occurred more in the trabeculectomy group, but again, it's interesting to see that complete success, there is IOP control without adjunctive anti-glaucoma medications were comparable in both the groups. So this is something I always, when I see this paper, I look at this and think, if they had sufficient number of patients in these two strata, these are the 4 strata in the TVT study. The first is just a previous cataract extraction, and unfortunately there are a good number of patients there. And then coming to this group, there is trabeculectomy with 5FU or combined procedure with 5FU or mitomycin, or trabeculectomy with mitomycin. If they had sufficient numbers here, it would have been an open and shut case. We would have known, we can give very strong recommendations on what to do if there is a failed fit. Do you do a repeat trabeculectomy or do you do a tube? Again, the probability of failure was higher with the cumulative probability of failure was higher with the trabeculectomy group. And they also did another ad hoc analysis where many of the surgeons said the IOP cutoff, the upper IOP cutoff they used in a TVT study was 21 millimeters or more, and that may not be sufficient for the group of glaucoma patients we were dealing with. So they looked at 17 millimeters as the upper range and 14 millimeters as the upper range in another analysis, and it seems to obey the same pattern that the probability of failure continued to be more with the trabeculectomy group. And this is another, the PTVT study, the primary tube versus trabeculectomy study. They found that preoperative intraocular pressure was a factor in surgeons choosing the trabeculectomy or the tube. The recommendations they gave. Tubes seems to be doing better with a higher preoperative IOP, and trabeculectomy seems to be doing with a lower preoperative IOP. Again, another ad hoc analysis they did. They looked at a preoperative IOP of less than 21 millimeters, 21 to 25 millimeters, and a more than 25 millimeters. And surprisingly, the tube group seems to be doing better as the preoperative IOP increases. Reasons for treatment failure: inadequate IOP reduction was the most common and most frequent for both the groups, and along with glaucoma reoperations were the major reasons for treatment failure in both the groups. But interesting to see that persistent hypotony was, this may be something which we don't see in our clinical practice, and again may be attributed to the, even though the authors have not mentioned this, may be attributed to the mitomycin use and the way it was applied. Surgical complications, again, there was no statistically significant difference between the surgical complications, although early postoperative complications were much more in the trabeculectomy group rather than compared to the tube group. Visual outcomes, same in both the groups. Again, risk of cataract progression was the same, was high in both the groups, both in trabeculectomy and tube group. Coming to the clinical applications, there are some clinical applications which the authors have suggested in their primary paper. This was one of the first studies which showed that a tube can also, you can also achieve IOP in the low teens with a tube. The general consensus among surgeons is you do a tube, you get about 80 in the high teens with a fixed drug combination. And again, the comparative surgical success rates of tube shunts and trabeculectomy with mitomycin not only dependent on the previous ocular surgery, but also dependent on the preoperative intraocular pressure. And again, experience and comfort level with trabeculectomy with mitomycin and tube shunt surgery are of paramount importance while planning surgery. This is extremely important. Actually, the TVT study provided support for the use of tube shunts beyond the surgical management of refractory glaucoma. And tube shunts and trabeculectomy with mitomycin have a similar safety profile in eyes with prior cataract and or glaucoma surgery, but the types of surgical complications were different for each procedure. They had more of motility issues with the tube group and bleb leaks, bleb dystasia, and shallow chambers with the trabeculectomy group. And again, this is also very important. What if you do a primary tube, what if it fails? So they have recommended that repeat glaucoma surgery following tube shunt implantation typically involves cilioablation or placement of another tube shunt, and repeat glaucoma surgery after a failed filtering surgery usually involves tube implantation. So outcomes of glaucoma reoperations were similar in both groups. Again, extremely important. So another thing was the visual fields and the quality of life were similar in both. And this is another interesting observation I saw in one of their ancillary papers. Tube penetration is effective in providing early IOP reduction after tube shunt implantation, but increases the risk of hypotony and hypotony-related complications. Coming to our surgical management, I am not entirely convinced the TVT study has had any role in this, but probably the threshold for a GDD in our practice is low if there's already a failed filter. There's a failed angle surgery in a primary congenital glaucoma, which about more than 14 millimeter cornea, several secondary childhood glaucomas, ICE syndrome, Sturge-Weber syndrome, and aphakia. Pseudophakia with a big superior SICS section, and neovascular glaucoma where we prefer to put in an AGV. This is another interesting report where they looked at comparing outcomes from the TVT and the PTVT studies. This sentence: in both the PTVT and the TVT studies, the efficacy of tube shunt surgery relative to trabeculectomy with mitomycin was greater at higher levels of preoperative intraocular pressure, with lower preoperative intraocular pressure benefited most from trabeculectomy with mitomycin over tube shunt implantation in the PTVT study. Do we have 1 more minute? Yeah. So just one case scenario. A 48-year-old male, monocular primary open angle glaucoma with history of glaucoma in the mother, first visit. Visual acuity, right eye is 6/60, improving to 6/12. Left eye is no perception of light. Baseline intraocular pressure 58/62. So you must have seen in your practice that patients they lose central vision due to very advanced glaucoma. They have severe visual disability. Advanced cupping with split fixation. Right eye IOP remained around 50 on MMT post micropulse post diode. These are the discs, and the somehow not very comfortable with AGV these days. We risked an RD after a complete informed decision with the patient and family. We had a drop in visual acuity at the end of 2 months once we removed the. And Supramid also seems to have increased the safety of these non-valve implants in our hands. Visual acuity dropped from 660, which is improving, to about 618, 612 to 660 now. But still, pressures are controlled. Some useful vision is being preserved. And now we also have the ACP 250 available, which may be a safer option in this. And I'm also proud to say that all of you can procure RD250 from Orolab now. And one last slide where Joseph Caprioli, somehow I have not seen this. It says the tube-assist trabeculectomy, it is in 2011, why its findings may not change clinical practice. He says whenever lower IOP is required, relatively high rate of complications in the TVT study is not universal. Mortality problems with BGI 350 is an issue. Relatively short follow-up. You need longer follow-up to see whether there are tube erosions in future. They have not looked at patients who have had no prior intraocular surgery, cannot be extrapolated to other tube designs, and established practice is difficult to change. Thank you very much, and I'm sorry for overshooting my time.
Thank you, sir. That was a wonderful presentation. Actually, we could hear from the person who does the most number of RD.